Good morning. We are so happy that you are with us this morning. We're so happy to present to you this morning as well. We are here to provide you 6 different modules in our presentation. So our presentation today is called Improving Quality Through Workflow Optimization. My name is Wendy Gonzalez, and I've been with HDN for 10 years now. I will be celebrating my 11th year anniversary on December of this year, actually. So I am part of the training and optimization team. And once again, I'm glad that you are with us this morning. Thank you.
Good morning, everybody. My name is Sandra Reyes. I'm part of the training and optimization team. I've been here for 4 years, and I'm the newest on the department. That's always the joke. And I'm so glad that you're all here, and I hope you learn and bring some knowledge back to your departments.
Yeah, you're not the new one. You're the newest on the team. No, I don't even like. I'm the lucky one. Good morning, everyone. My name is Brian Devienne, and thank you guys for joining us here today. I know you're taking time out of your productive day to come here and spend an entire day to go over improving quality through workflow optimization. I've been with Health Choice Network for almost 14 years, and I've filled many capacities, if you will, within the network. But as Wendy and Sandra just mentioned, as part of the optimization and training department, predominantly what we're focusing on, aside from implementations, is figuring out ways, which is what you're going to hear about today, where we could actually begin to talk about quality and what that means to you, and ways where we could actually think outside the box when it comes to process redesign and analyzing workflows, and talk about teamwork and other stuff like that. So with that said, I think Wendy's going to go over some disclosures and some acknowledgments, and then I will be kicking it off. Thank you.
Thank you, Brian. So as I mentioned, our presentation is called Improving Quality Through Workflow Optimization. As you probably already know, we are working with the UAB, University of Birmingham, Alabama, and the ONC, where we have a 2-year grant where we've had to train 1,000 providers. So I thank you and our member centers to allow us not only to meet those numbers, but to exceed our numbers of providers that we have trained. So this is the presentation that we've gone around in multiple states to present. So we're glad to conclude here, per se, in our show, our road show. All right. So on our agenda today, we're going to talk about what is quality and knowing your measures. We're also going to talk about workflow optimization, some key system setups, both in Energy PAMIS and Energy EHR, also working as a team, reporting and outcomes, and then we're also going to talk about change control and onboarding. So I'm actually going to go ahead and pass it over to Brian now, where he's going to kick us off with understanding what is quality and understanding and knowing the measures.
Thank you, Wendy. So yes, we're going to begin defining with this part of the presentation really what, in your mind, what I'd like to hear is how you truly define quality. There will be a couple of definitions that we bring up here from the Institute of Medicine, as well as the Agency for Healthcare and Quality Research, in terms of how they define quality. So the idea here is really not for all of us to be waiting for me to ask you whether or not you know a specific measure, but it's those specifications, it's the knowledge of knowing what those measures are that impact quality, is really what this first segment is all about. Yes, you are going to hear about the downhill design. Yes, you are going to hear things like huddles and ways that we can, review workflows, or before we actually redesign a workflow, analyze a workflow and understand what that means when we're understanding how to fill in care gaps. So really the idea here is when we talk about what is quality and knowing your measures, is simply understanding what the specifications are, really knowing what it means whenever someone says, did you actually capture that clinical measure? Not just did you capture that clinical measure, do you understand what it means when we talk in quality measures in terms of a quality measurement year, what does that mean? Did you drop the charge for the HEDIS code? What does that actually mean? Because I know a lot of us in here spend a lot of time defining what the measures are, so we understand in our mind what each one of those are and what we need to do in terms of capturing that information in the EHR. But this is taking totally a different turn to make sure that we all understand here, what does it really mean to know your measures? So yeah, we are going to be defining what that means in terms of quality. We are going to dive into a little bit of the DQM process, right? Data quality management. I know we have some data quality managers in here. And get a better understanding of what that means when we talk about attributes of quality. It's not just capturing that data, but you want to be able to take that data and make it what? Turn it into useful or meaningful analytics, which we'll be talking a little bit about as well. Some key process recommendations for maintaining integrity and the use of health information technology, as well as talk about the differences between poor data and meaningful data. Okay? So I'll first start out by defining quality. And up here you have two definitions. And looking at these definitions up here, kind of compare that to how you define quality. Depending on what it is that we're talking about, whether it be the patient, whether it be a performance measure, whether it be the type of work that you're doing whenever you clock in, what type of quality, and is it safe? Is it effective, right? Patient-centered. Is it done in a timely manner? If you'll notice, both the Institute of Medicine and AHRQ, the definitions of quality are pretty much the same. But before I dive more into quality and talk about the definitions of knowing your measures, what I want everyone to understand is that ultimately, right, we are here to improve, right, the health and life of the patient. So in terms of quality, yes, we can refer to quality as, right, managing our time. We can refer to quality as making sure you've dropped the performance measure so the information can be captured and we can turn that data into something meaningful. But at the end of the day, if it's not improving the health and life of the patient, then we've actually lost the mark. We've actually missed that target. So because we are going to be diving into many, many different areas throughout the day, I don't want to lose focus truly on the quality aim. So let's talk about why we measure quality, right? Why measure performance, right? So having data is really not that important. I don't know if you all caught that quote in terms of numbers being boring, right? So what can we do? What intel, what brains, right? What can we do to make those numbers better, right? Understanding the specifications or knowing your measures is one thing, right? But what is quality performance measurement? Well, we're collecting data today. We have an application that collects data. We warehouse that data, we analyze that data, and we turn it into useful information. And guess what? We start that data quality management process all over again, right? To try to make it better and learn from the data that we're capturing. Why do we do that though? Why is the question. So in terms of, right, centers out there or anyone that wants to be a quality improver, I need to be able to compare my data against other health centers to see what they're doing, right? How does my information stand up to other health centers? So yeah, in terms of quality improvement and making that information transparent and understanding where you rank in terms of your quartile is extremely important. Accreditation, we all know about that, right? For those of you that participated in Cindy's presentation, you understand how important quality is, right, when we talk about PCMH, Patient-Centered Medical Home. What about AAHC, Joint Commission? All the work we're doing for UDS, right? There is a reason behind that, right? Accreditation is almost like stars, right? When you're doing a simple search for a hotel, you're looking for stars, right? A lot of you guys in here Yelp and you're looking for restaurants to go to places and eat. You're looking at accreditation because those are the places that you want to go to, right? PCMH recognition, I mentioned a little bit about that already. And last but not least, incentive programs. These are just a few. Actually, more than just a few. A few to me is 3. But we have up here reasons why you want to measure performance, and there are many different incentive programs out there that stand behind quality. Unless you're able to prove, right, then the incentives tied behind those programs will not be given to you. So yeah, there's many reasons why we focus on quality. And what I want to talk about now are just some of the basic fundamentals of the importance of quality or the impact of not meeting quality, right? Yes, quality can be defined as dollars, right? Quality can be defined as, how the patient feels whenever they walk up to the front desk person and they're greeted. Okay, quality can be determined in many ways, but I want to talk about here just some of the basic foundations of quality and why it's so important and the impact of that when we talk about UDS, HEDIS, meaningful use, and again, the quality aim. So let's talk about that first one. Does everyone in here understand the impact of quality when we talk about UDS and why it's so important that data that's collected every single day and reported to the Bureau is so important when we talk about quality? Okay, what I want you to take away from that first block there where we talk about UDS data is your 330 grant funding, right? Your 330 grant funding is the basis of many reasons why FQHCs are able to operate as a federally qualified health center. So without quality or being able to show performance, you're at risk of losing your 330 grant funding. So guess what? You lose your 330 grant funding and then what happens? You can no longer operate as an FQHC, correct? How about HEDIS data? The terms up here are very familiar because we all talk a lot about what PCMH and UDS and HEDIS. But really, when we talk about HEDIS, right, what is NCQA pushing down to the payers in terms of how they measure performance, right? So when we talk about capturing HEDIS codes, when we talk about dropping HEDIS codes, there's a reason behind that, At the end of the day, when a provider is documenting, they're literally being told what to do. Maybe not so in a manner like I'm up here speaking to you so you understand what it really means to know your measures, but it helps to know that whenever we're capturing information for the Bureau, or capturing information for a payer, for a health plan, there's a reason behind that. They're measuring quality. And in order for us to transmit that information to the health plans, who are ultimately regulated by NCQA, right? How do we get that information to them? Because ultimately, at the end of the day, that's what they're looking at. They're looking at the information that we're putting into the system. So, as I mentioned, when we talk about the downhill design and understanding how information is captured in the system, you have to understand workflows. You have to understand how information is being captured, not just by providers and support staff, but by the front desk as well. It all actually starts at the front desk, and you're going to be hearing about that soon. How about grants? High-tech. And the reason why we threw the High-Tech Act up there is because back in 2009, for those of you that are not aware, there was $27 billion, right, invested into what we know today as meaningful use, right? Making EHRs more prevalent so that we can capture data, make this data useful, right? But we needed the money for what? Investments in technology, right? Understand how to capture data and report data. So yeah, the reason why grants is up there is because there's also an impact on poor data when we talk about quality. Because again, it's an incentivized plan, which means I need for you to show me that you're using the system meaningfully. So we will not be focusing on stage 1, stage 2, stage 3 when we talk about meaningful use. When we talk about meaningful use now, right, we need to make sure that the system is being used meaningfully because now we need meaningful analytics. We need data, we need information. We need intel so we can make a difference when we talk about the quality aim. Everybody remembers what the quality aim is, right? Improving the life and health of the patient. So yeah, quality has an impact not just on your 330 grant funding, it has an impact on health plans. And you're going to learn some of those consequences in just a moment. We already just talked about grants and how incentivized programs are definitely, okay, focused on quality. And last but not least, the patient, right? We've all been subjected to walking into a health center, or maybe a restaurant, or maybe a department store, right? What happens when you're not treated right? Okay, so we can talk about dollars and cents, but we can also talk about what the patient's expectations are when they walk into a health center and how that impacts quality. They will turn around and never come back. So these are just some basic ideas. Actually, this is reality when we talk about key revenue. But these are actually key revenue sources when we talk about the impact of poor quality and how that impacts UDS, HEDIS, meaningful use, as well as the quality. And I did mention when we were talking about accreditation, there's other agencies that are not even up here that we're actually doing work for as well in terms of the stars, if you will. So yeah, knowing your measures is extremely important. That's really what this is all about. Understanding what the impact is when we talk about quality. So let's talk a little bit about HEDIS. We'll talk a little bit about UDS, and then present to you some factual numbers in terms of where we are as a network. Get familiar with quartile rankings and understand how the Bureau makes those adjustments so they can compare themselves with other national quality leaders. And finally, like I mentioned earlier, we'll talk a little bit about the differences between core data and meaningful data. So yeah, up here we have what you must know about HEDIS. Okay? Healthcare effectiveness data and information set. So for those of you that don't know what HEDIS is, I like to say HEDIS is a performance measure, right? How effective is the data in terms of the information that we're giving in CQA? The information that we're supplying to the health plans, right? So in terms of HEDIS, there are actually 81 measures, right? And just over 30 of those are focused on ambulatory care. So the key thing here is in terms of preventive measures, primary care, right? Comprehensive diseases, such as diabetes, for example. How is that information being captured? And how is it being transmitted to the health plans and ultimately CMS, Center for Medicare and Medicaid? How are they actually receiving this information and understanding how well health centers are performing? So here's just a simple idea, okay? There's a whole lot going on here in terms of patient care, right? There's a whole lot of information going on there, but ultimately, CMS, who's providing the assignment to the health plans, is really, right, getting this information from who? Correct, they're getting the information from the insurance plans, right? Which means that the insurance plans must be getting that information from someone, right? And who is that? That's us. That's the community health centers, right? The patient's information that's being documented in the health record. So yeah, the information is being captured during patient care and obviously being transmitted. There's many sorts of ways that information can be transmitted to the health plans, which we'll talk about here in just a moment. But the real important thing to remember here is what are those consequences for not meeting those HEDIS targets? Just like there are consequences for not meeting certain targets when we talk about UDS, the same thing happens here when we talk about HEDIS, right? Some of those could be what? Revenue loss, fines from CMS, right? When we talk about quality and the impact of not meeting those targets, decrease in payment rates, loss of quality bonuses. So yeah, there are some serious consequences when we talk about not meeting those HEDIS targets. So how does that information, right, get transmitted? So primarily it's what? It's that first bullet there, right? Claims data. So the information that's being captured is being placed on a claim which ultimately is being reported to the health plan. Right? So yes, through medical office visits, procedures that are being captured in the system, performance measures that are also being captured in the EHR. Some other ways, okay, some less traditional today, but yes, healthcare surveys, medical chart reviews. Ways to improve performance. Something looks a little jumbled there. I don't know exactly what happened there, but what are ways that we could actually improve, right, performance measures? How can we optimize what we're doing today in terms of capturing some of our performance measures? So yes, learn and understand heat is specific, right, to your specialty. When I say knowing your measures, when I talk about knowing your measures, that's really what we're trying to say here is learn and understand that. Not just learn and understand how to use the forms, right? Not just learn and understand the steps to register a patient, right? Or maybe organizing the pages during registration, or organizing your navigation buttons in the chart. Those things help with workflows, but unless you understand things that are specific to HEDIS, things that are specific to UDS, and I'm talking about, yes, learning about the definitions, the specifications, right? The numerator, the denominator, right? Your targets, okay? Any exclusions that might apply. It's fully understanding what those needs are and why I'm having to document this way. Utilizing health information technology tools at your disposal. And last but not least, capturing data, right, properly, which is one of the attributes of data quality management. There's actually 10 attributes we're briefly going to discuss here momentarily, and that does happen to be one of them. Now, in terms of UDS, okay, we've talked a lot about UDS here as a network, but yes, UDS, the Uniform Data System. We talked about that and the impact of quality of not meeting your UDS targets, right? The impact on your 330 grant funding. But basically, yes, a lot of information is captured during a UDS visit, but what I really want everyone to know here is whenever you see a patient or there is a qualifying UDS visit, right, the health center basically becomes or has ownership now over that patient in terms of everything now that must be, right, everything that must be satisfied during that quality measurement year. Okay, so things do compound in terms of risk when we talk about meeting those UDS targets, especially when patients, walk into a health center around this time, where you have about, 6 months left in your quality measurement year, and things become very challenging. Okay, so yes, we'll talk about the impact of PCMH, right? And when we talk about integration, right? When we talk about huddling, right? When we talk about care teams and the importance of patient engagement. There's a lot going on when we talk about meeting quality. So up here, as I mentioned, we will show a few numbers in terms of, the impact of quality, or in this case, how much of a priority is quality to HRSA. Okay? So yes, when we talk about awards, okay, kind of steering away with the impact of the quality aim, but when we talk about quality improvers, right? When we talk about money that is pushed down to health center control networks, when we talk about PCMH recognition, okay, the focus there is how well did you perform in a particular area, okay? So if we just look at a few of these here, when we talk about HCCNs, health center control networks, PCMH recognition, and our quality improvers or quality improvement awards, as you can see, there are, right, incentives for meeting these quality targets, right? If you look at Health Center Controls Network alone back in 2016, 50 awards were issued that totaled $36 million, right? How about PCMH? 246 awards totaling over $8 million. And when we talk about your quality improvers, over 1,300 awards, right? Totaling $100 million. So yes, there is an incentive for meeting your quality targets. With that said, when we look at performance data, okay, the purpose is to understand what your benchmarks are so that you can see over time that you are improving when we talk about quality improvement. So yes, to be a quality improver, you have to show improvement over time, which is the reason why this information that you see up here is data this is data that is accessible online. This information is transparent. Health centers, leaders could actually bring down this information to compare themselves in terms of where we need to be. So yes, these goals that you see up here are in line with the Healthy 2020 goals. So for those of you that understand what your Healthy 2020 goals are, they are actually in line with not just UDS quality measures, right? They're also in line with your Healthy 2020 goals when we talk about where we need to be in terms of that particular measure. Over on the right, which is that last column there, that is actually the first quarter range for the network. The reason why you see a range there is because that is actually the information that we've been able to capture now. So, for example, when we talk about access to prenatal care, the goal is to be, right, greater than or equal to 77.9%. So when I look at that, I say, okay, we have health centers, okay, that are not at that mark yet because the lowest we have is 41.1 and the highest we have is 100%. So it's understanding what we need to do to get those centers that are not at their target and figure out, is it a workflow issue, right? Perhaps documentation, training, technology, okay? Perhaps it's information that's just not being communicated, okay? So yeah, this is really here for just information to understand that, yes, here are your numbers, okay? I know it's not broken down by center here or in terms of how many centers are at 22% versus how many centers are at 82%. But when I look at that and say, okay, for cervical cancer screening, I know that I have to be at least 93% or higher in terms of my compliance percentage. So when I look at it as a network, okay, the highest is 82%. So we already know that we have work to do, okay, in terms of meeting this measure. Keep in mind that these are progressive measures, right? Meaning these numbers should be going up throughout the measurement year. And when we look at these dates here, 2013, 2014, 2015, you could actually see whether or not there's a gradual increase, right? Or maybe a plateau, or maybe you went down, okay? There is something called an adjusted quartile ranking that basically takes these quality measures, but it also throws in characteristics of health centers, right? Because not all health centers have the same population. Not all health centers have the same amount of insured patients. Not all health centers see homeless patients, okay? So yes, there are some different characteristics when capturing these measures that impact the ability to be quality improvers. So you know what? Let's adjust these rankings, right? And get a better idea of where we all are in terms of what quartile we're in. So this is actually information that's available on the Bureau's website as well, where you could actually dial into a specific health center and find out what their quartile ranking is. You want to be in quartile 1, which is at the top 25%, right, compared to all other FQHCs in the nation. So yeah, if you're in quartile 1, there's always room for improvement, right? But yes, if you're in quartile 1 in any of these quality measures, you're basically at the top 25% in terms of meeting that measure compared to all other health centers in the nation. So what do you take from that when you see areas, for example, that are not in quartile 1? You're in actually the lowest quartile, which is the bottom 25%, which is quartile 4. What do we need to do to improve? How do we become quality improvers? And it starts with knowing your measures. It starts with understanding why this particular measure, for whatever reason, staff is having difficulty meeting the targets. Perhaps it's workflow, training, like I mentioned. You know, the communication is just not getting there. So yeah, when you look at this, you'll notice you'll see colored arrows, right? So a red arrow would mean that during that measurement year, we went down a quartile. If you see anything in green, you actually improved in that particular measure. There are a few things in there that didn't have any data to report from the previous year, so you'll see those yellow arrows in this demonstration here, right? And for those measurements, for those quartiles that actually didn't change, you'll see the arrows pointing left to right there, just letting you know that nothing changed during that time. So yeah, it's important to know this stuff because in your mind, it's going to impact what we're doing whenever we're documenting in the EHR, right? Whenever we're capturing information in registration, such as veteran status, homeless status, the email. Little things like that have such a huge impact when we talk about quality. So these last few slides, I'm going to briefly just go in through, I've talked about this a little bit in terms of the data quality management process, in terms of how that information is being captured and what's happening once it's collected. Okay? So yeah, in terms of application, information is already being collected, but before it could actually be collected, right, warehoused and analyzed and turned into useful information, this is the area where we talk about some of those things where we need to figure out where are the gaps. Is it the workflow? Is it understanding what the measures are? Because the application that we're using today, right, is Energy EHR, or in terms of Dentrix, in terms of dental, it's Dentrix. So yes, information is being plugged in an application and being collected. So this is a process that's happening. It's almost like a PDSA cycle that's happening throughout the day. Applying that information, collecting it, warehousing it, and analyzing that information. What's in the middle, though, are those attributes that I want everyone here to be familiar with when we talk about characteristics of data. And making sure that the information is relevant, right? Timely, precise, to the level of granularity. That is the real important information, is the work that goes into the data quality management process. When we talk about outcomes, there's a piece in here where we talk about garbage in, garbage out. We already know the difference between poor data and meaningful data, and that's exactly where this is going. So understanding that data quality management process really doesn't mean a thing unless you have characteristics that exemplify quality characteristics when we talk about data. So yes, accessibility, consistency, currency, granularity, precision. My favorite one is definition, because it kind of ties back to knowing your measures, right? And understanding how measures are defined, understanding the specifications, and knowing the reason why I'm doing this is because it's tied to a particular quality measure. So I need to learn not just how to use the application, I need to understand and have those quality measures sort of defined in my head in order to impact characteristics of capturing good quality. So yes, you could actually find this information online in terms of the DQM process as well as the DQM attributes and learn a little bit more about what those characteristics mean, right? One that always stands out whenever we're doing this in front of health centers is timeliness, because time is always an issue. Not so much is the information, right, being given to us in a timely manner, because that's important as well. A lot of times measures will change throughout the year. So timeliness is extremely important because we're in a quality measurement year period. We need to get the numbers where they need to be. Time becomes a huge impact. Time is also an impact when it comes to capturing that information. So you need to look at this a little differently as well when we think about data quality management, because if the providers don't have enough time to capture the information, it's going to impact the characteristics of this information we're capturing here. So again, talking about the downhill design, right? Process analysis, process redesign. There's a reason why this presentation goes into workflows, working as a team, right? So you can understand where we can impact characteristics of data quality. And finally, comparing poor data to meaningful data. So what I would like for you all to really understand here is the true impact when we talk about poor data and not being able to, right, decrease operational costs, when we talk about decision making and the inability to execute organizational strategies. Yes, quality impacts not just the patient, not just some of our programs, but when we talk about operational costs, decision making, right, being able to execute organizational strategies, poor quality has an impact on that, okay? But most important, again, is the quality aim, and obviously patient and staff, right? Dissatisfaction. Staff is also important too. But ultimately, meaningful data or meaningful analytics, okay, it's kind of where things have kind of shifted. We've gone from meaningful use to now really looking at data and finding out, is the analytics meaningful? So the little picture you see here, or this snippet that you see here, is really giving you a bigger idea, the real bigger picture when we talk about health information exchange. So yes, you have the prevalence of EHRs when meaningful use was rolled out, right? But at the very end, you have that ultimate goal of being able to exchange data. Not at the local level, right? Not at the regional level, but at the national level. So what do we need to do to be able to exchange health information, right? When we talk about data quality and knowing your measures, right? That's truly our ultimate goal. And with that, we should be able to what? Reduce claim errors, right? When we talk about using an application in a meaningful way, we should see better communication and continuity of care. Am I correct? What information can we take from that for education and research, right? Quality of care, of course, accurate, timely claim review and payment. Those are just some of the benefits of making sure that we meet those characteristics of quality data. So with that said, we're going to be talking about our next segment here and going into workflow process analysis. So before we transition, does anyone have any questions at this time? Thank you.